Thanks everyone. My name is Jing for those who don't know me. I'm a senior research fellow at the Centre for Health Economics, Monash University Business School. So I lead a team there that does a lot of feedback evaluations. And I've always been interested in this reveal preference area and also decision making more broadly. So thanks very much to Emily and Kirsten Reike for getting me involved in this research. It's been an absolute privilege and been wonderful collaboration so far. Okay. Oh, what are we doing here? Okay, so the motivation for this study is, as we've heard, there's this vast state of preference literature, including the results from Torch itself, the Peasgood and Martin systematic review, plus the state of preference study just then, that we've just heard the DCE just then, indicating the public support for giving greater weight to identical health gains in children versus adults. And many HTA agencies do include aspects of equity in addition to health gains in their decision making. You know, it could be need, potential years of life lost, etc. Age is informally considered by lots of agencies, but not in an explicit way. And another thing is, we're in Australia, and the PDAC did lead the world in requiring economic evidence in all HTA submissions, and, you know, part of that rational decision making. So we've got 30 years of accumulated reveal preference that can be studied. And another thing is, so a really important question is to ask, well, do the reveal preferences for child versus adult drugs in PDAC decisions mirror the findings that we're seeing from state of preference literature? And another aspect of novelty with this study is that age had not been studied in previous reveal preference studies for PDAC decisions, nor any HTA decisions from any agency, to my knowledge.
That's the age of the patient, not the age of the PDAC.
Yes, correct. Okay, so just an overview of the methodology. We constructed a data set of evidence presented to the Australian Pharmaceutical Benefits Advisory Committee from public summary documents. These were available from July 2005, so we went all the way back to July 2005 and extracted data on the PDAC's views on the evidence for all submissions from the start, July 2005 to November 2023. And there were 2,395 PSDs. And we extracted that information following a predefined template. And then from that, we identified submissions for child only or child plus adult population versus an adult population. And then from there, we then econometrically tested whether interventions affecting children were more likely to be recommended for public subsidy compared to interventions for adults, controlling for other factors that impact decisions. Okay, so a little bit more about the identification of paediatric submissions from PSDs. So I mentioned there were 2,395 PSDs that were screened to see if the intervention was for a child. And we use keywords: child, less than 18 years, adolescents, infant, ped and ped, just to, you know, take care of the British and the American spelling of the word. And from there, we identified 708 that were further screened. And then from there, 185 got excluded because they were only for adults. And then that left us 171 PSDs for child only and 350 for child plus adult population. So in total, there was 524. Okay, so just want to cover the type of submissions that we have in terms of the type of economic evaluation presented. For those not familiar with it, we extracted data on all types of submissions. So you can get cost minimisation analysis. What that means is it's being deemed as non-inferiority on the clinical side. So it's not better or worse on benefits or side effects, and the economic analysis just goes into a comparison of cost, meaning the new intervention should be costing no more than what's already there. Or you could have a cost-utility analysis, in which case there is a difference or a benefit in terms of either efficacy or safety, and there is an elaborate modelling that then goes on to try to estimate an incremental cost-effective ratio expressed in terms of incremental cost per additional quality adjusted life year gained due to the intervention. Or another way is some people are I think it's more common in the past, there are cost-effectiveness analysis where the benefits are expressed as health units. It could be, cost per additional responder, for example. Or cost consequence, where they're not looking at the benefits, they're just comparing costs. Some of the submissions presented no economic evaluation, and there was one that presented a cost-benefit analysis, which translated the benefits to monetary terms. So in our analysis, we only looked at submissions with a cost minimisation or cost utility analysis. And the reason for that was because we wanted to somehow make the outcome on the same plane, and it was very difficult with the other ones. And so the incremental cost-effective ratio for cost minimisation submissions, we impute that as 0. That's just based on the principle of cost minimisation analysis being non-inferior on clinical benefit or safety, and we're minimising costs. Oh, sorry, that's what I'm saying, using those. Okay, and then in terms of, if you just look at that subpopulation of cost minimisation plus cost utility submissions only, then we are left with 1,661 submissions, and you can see only a very minority, 88 of those were in child only, 217 in child plus adult, and the rest were in adults only. Very odd. I did have a nice right-hand side, but it's gone. Okay, so these are the... Oh, do you think? Okay. No? Oh, I'm going to go back. Yeah, so that's meant to say independent variables of interest. And the orange block highlights what we're looking for to see if there's a difference in submissions for child plus adult versus an adult population. But we're also controlling for these other attributes that are known to be important in PBAC decisions. And these include whether there was considerable clinical uncertainty associated with the clinical data. If there was a clinically meaningful benefit for the intervention, and whether there was considerable economic uncertainty associated with the modelling and the outputs from that, and the incremental cost-effective ratio as a value, as a measurement of the value for money of the intervention, and also the budget impact. Here we just define it as if it's going to cost the PBS more than $10 million per year. Okay, so just to show you on one of the variables, the ISA. So what's available to us from the PSDs are categorical ISAs. We don't have the actual continuous variable, so they've been more or less put into these bands, and you can see within each band there's a good spread. It's sort of pretty consistent in terms of child plus adult versus adult, number of proportion adult submissions, except when you get into the more than $200,000 per QALY bracket, and that could be because there's a difference in proportions, but also there's much fewer submissions in that category, so you naturally see funnier results. Okay, and then in terms of the dependent variable, so this is the outcome we're looking for, and that's the PBAC's recommendation, and that's not super straightforward to code as well, or to extract from the PSDs, because the PBAC can make different types of decisions. So some submissions are just rejected, or the terminology is not recommended for that listing. Some can be listed at the price requested and, more or less consistent with what's being requested. So they are more straightforward, consider recommend. The PBAC can also recommend with some sort of criteria, either requiring a risk-sharing agreement on the volume sold or the volume and the price for the drug, or a managed access scheme, Sometimes they make a recommendation called list similar in class. It's not usually called that, but we just call it that, but it just means that they think it should be cost minimised to an existing product rather than with a price premium. It could be list at a lower price. I think in recent years that's less frequent, but in the past that was a type of recommendation. They can also defer a decision to a future meeting, and that's usually due to processes outside of the PBAC's control. For example, they're waiting for the TGA registration to come through because the PBAC cannot recommend something that's not yet TGA listed. And so on occasion they just provide advice and no real listing decision occurs. So in terms of our modelling, in the primary analysis we exclude, we only include when the submission if it's a reject or if it's list at the price requested, and the rest are excluded from the analysis. But because the coding of the list with criteria it's not always super clear from the PSDs, we do a sensitivity analysis where that's also included as a recommend as well, and the rest are excluded as per the table there. Okay, so here is the descriptive statistics for PBAC recommendation by population and split by the two definitions for recommend. And you can see in the first lot we've got 1,243 decisions, and then in the second lot 1,436. And I think even on the raw statistics you can kind of see a slight difference in the proportion recommended when you go into the different populations. And so we've done a logistic regression. And that was because it fitted our data well. We've got basically a binary outcome, and we think the outcome from the logistic regression is easily interpretable. Okay, so this is a very busy slide, so I'll run you through the results. So what we get from the logistic regression are odds ratios. When the ratio exceeds 1, that means it is more likely to get a positive recommendation versus the reference category. And you can see in the red rows that the child category is consistently more likely to get recommended by the PBAC, controlling for all the other factors that are in the regression. This is also kind of true for child plus adult, although it only reached statistical significance when we just consider the subgroup that were cost per QALY only submissions. Then I guess we need to look at the controls to make sure that they all make sense. And you can see that they pretty much go in the direction that we'd expect, and they were pretty much, most of them were, they were actually almost all were statistically significant. So if there was lots of clinical uncertainty, there was a lower likelihood of getting recommended. If there was lots of economic uncertainty, it was also not likely to get recommended, and the higher ISA bands were less likely to get recommended compared to the lower ISA bands. And if the budget is more than $10 million per year to PBS, it was less likely to get recommended. We did an interaction for clinical important effect and cost utility, because we control for it because we think they're a bit different. The cost utility type submissions and the cost mean submissions are just a little bit different. It'll be incorrect to treat them exactly the same. And you can see that clinically important effect was very important. What's trendy important in the primary analysis, but certainly important when you just look at the cost per QALY only subset. And there's also a preference to recommend the cost utility only submission, cost utility submission compared to cost mean when all else being equal. I suppose that's also intuitive in the sense there's a benefit to be gained there, whereas cost mean, naturally there's no gain. Okay, so in summary, the past PBAC decisions suggest drugs for children are more likely to receive a positive recommendation compared to interventions for adults. A positive recommendation is also more likely for submissions for a child plus adult population, but this was only statistically significant in submissions reporting a cost per QALY outcome. And then I guess the question you may have is, how do we know the committee cared about child in their decision making? And I think that comes down, hopefully that can convince you, down to our identification of submissions for child or child plus adult populations as they were directly identified from the PSD. So if they were mentioned, we used a keyword search to pick up those terms. And I think that's a much more precise identification that the decision maker did indeed take the child population into account in their decision making. So I think that's a strength of the paper. And then, thanks everyone, and want to special acknowledgement to all the co-authors, especially Tony, Raki, Kirsten, Emily, and also Duncan, that we met quite consistently throughout this process. And also special thanks to my team of PBAC evaluators who extracted the data from PSD, because with the data we can't do it. Thanks.
Any questions or comments?
Thanks,
Thanks for that analysis. Just a couple of thoughts that you might want to think about in the analysis. I think you probably need to think about an interaction between the child and the budget, 2 lines, because if you think about it, their childhood diseases are not very frequent, so they have a lower budget. So you've got an actual interaction going on between those 2 terms in the model. And I'm sure that is part of our reasoning when we look at these things. It's easier to make a decision because the total budget impact is likely to be less even when the drug's price is very high. The other thing is, and Kirsten or Andrew Mitchell might have a view on this, I'm wondering whether you shouldn't exclude the vaccines. So PBAC also, for those who don't know, also has considers vaccines, which then go on the National Immunisation Program. And there's a sort of, it's not an artificial threshold, but for most of the childhood vaccines, there's really sort of a limit to what we sort of commit to. So they have quite a high, potentially have quite a high budget impact because of there you're talking much larger numbers, but we actually sort of have quite a low threshold for acceptance in terms of the ICEs in it. So I'm just wondering whether it's worthwhile taking those out, but Andrew and Kirsten might have a sense of that.
I think that's probably worth doing as an additional sensitivity. It's probably worth doing as an additional sensitivity analysis. Because you're right, they are inherently different in that way. Just as a comment, I was looking at the dates, and given that I started on economic subcommittee in October 2005, that number is incredibly scary. 2,400 submissions. Yes.
So I think the common feature that Andrew's pointing out, I would characterise this possibly slightly differently, it's worth looking at because it would be slightly larger numbers. I mean, relatively few numbers of vaccine submissions compared to medicine submissions, so it's probably not going to make a big difference. But if you added Hep C meds and cholesterol/hypertension meds, and I don't think there will be many nowadays, the common denominator was a population health intervention where the impacts were relatively asymptomatic early and the real benefits occurred many years into the future. And PBAC and then subsequently MSAC for screening and related type of programs, like Andrew just said, dropped the cost-effects ratio. It's kind of like, as you were saying, the big tail at this end, there was some submissions where the range of acceptable cost-effectiveness went the other way. And it's kind of like a balancing effect. If you're going to give benefit of the doubt here, then there's got to be some sort of balancing act going anyway. I had another question. I've got the mic. How did you handle resubmissions? because I wonder if that's another aspect. You'll certainly have a lot more resubmissions in that data set if you've just taken any submission, whether or not that's real or not. And in particular, whether there is an interaction between the subsequent submission and the early submission, because the truth of the matter is that by definition, resubs tend to eventually get more recommendations than initial submissions. And if there's a different proportion of resubs in your younger population to your older population, that might be worth just investigating.
Thanks for the questions. Yeah, so I'll answer Andrew's question first about the resubmissions. We haven't really taken resubmissions into account in this one. I mean, we can, but I think our goal when we set out was just to, look at all the submissions and see if there's an effect first. So we were not too worried about resubmissions, I suppose, I think, we were trying to be including all the child submissions. There's not many, there's only 88. And then I think I've got a question for Andrew about the vaccines, because, so there's only 88 observations in child, and
I think, while it's true, Andrew, that overall the number of vaccines is not high, in the child-only vaccines, there'll be more, particularly as you've included COSMINs, and there are lots and lots of variations on vaccines that come through as COSMINs. So for any particular condition of for the common vaccinations, there may be four different vaccines considered for the same condition, and they'll all be essentially COSMIN.
Yeah, I mean, it's a good suggestion. We can definitely have a look at it. My only concern is, I think in the adult population, we would have vaccines as well, because they're all included. So at the moment, I'm comparing childhood vaccines versus adult vaccines, because they're still in there. If I take out the childhood vaccines, do I also take out the adult
vaccines? I'd take them out.
All vaccines.
Take them out and treat them separately.
Could you rather than taking them out, could you not just put an extra variable into the variable list that is a population health benefit?
You can, yeah, you can. So there's different ways. And then I have another question. Sorry, it's about the vaccine as well, because in my head I feel it's quite difficult to tease out the various different things that might be associated with being a child, having the child status. And that could include that there will be more preventative treatments for children when they're young. And should I actually be separating it out? Because they do get more of it, but I am representing the child, because I'm not, I can't tease out everything
well,
that
I think
they
you
get.
need to think about the implications of it. I think you also need to think about the implications of what the COSMINs mean, because basically what a COSMIN means is one drug's being considered cost effective, everything that comes after it is COSMIN to that. So a COSMIN is much more likely to be accepted than the initial submission.
Yeah.
So if you're including all submissions, including all COSMINs, then that will have an effect. I can see, I think it will actually make a difference bigger, because we're more likely to get multiple COSMINs.
It does. So that grey column is all including COSMINs, and the column next to it is excluding COSMINs.
Right.
So your effective age is greater for children alone. Most of the other things that's quite similar, but
Just playing devil's advocate, you could do LSDP drugs, which are less likely to recommend and are quite prevalent in the paediatric population than the adult too. Just wonder, I mean, I can see this thing swing multiple ways. I'm interested in the child plus adult.
Well, the LSDPs will actually be represented in there as
Because they've
not recommended.
Exactly, so that there'll be a higher, in the recommendations for vaccines and spinning out. That's what I mean by going both ways. The adult plus child is interesting, because I'm just trying to figure out what the PSV would be actually saying. And I understand the primary problem is interpreting this bunch of words as to what was behind the scenes. I mean, I would have thought that a child population identified separately than an adult is probably going to be a different restriction there's very rare recommendations that PBS says this is for patients above an adult range. Generally, if they list without reference to age, you can treat for children. So the absence of an age limit means that PBS is often intentional in allowing it to be used for children. So to find a third or middle category, I mean, it's obviously working in the way that you kind of hope that it's intermediate between adult and children, but I have no idea what really that middle group actually means. I can't conceptualize it.
So it's not based on the like the PBS restriction?
So it's not, when we were screening for it, it wasn't really like we screened for the PBS, requested listing, was for a child, whatever, because we know that the PBS and the PBAC did not want to put limits on age. Especially, I think it gets quite hairy when you get to a 17-year-old versus an 18-year-old or a 16-year-old. It's just, those fine lines are very difficult to cut. But that's why we screened the entire PSD to see, if they mentioned those keywords. So that shows to us that they had, when they were deciding, at least considered. Yeah, that's right. Yeah.
Jing, sorry. Lots of questions you've got this time. I've done some work, as you know, on PSDs and looking at predictors of PBS funding. We excluded resubmissions because of the collinearity between having a resubmission and the original submission in affecting the decision. Have you thought about doing, since you included resubmissions in yours, have you thought about rerunning the logistic regression with the robust variations so that it's not going to be affected as much by the collinearity issue? Just might be worth doing because it might get picked up in peer review.
Yeah.
Well, my gut feel is that there are less resubmissions of pediatric drugs than there are for adults.
These are all really good questions. I'm writing them all down.
Yeah, thanks, Ginger. Really interesting work. I had two questions. The first one, I think we might have discussed this at one of the earlier meetings, but is the quality of the evidence of the contributing submissions accounted for? That's not accounted for at the moment, is it? So we're not sort of assessing the quality of the contributing submissions?
I think it's indirectly reflected is probably, I'll show you the, so I've got that, oh sorry, no, actually this is a
So
good
the
slide.
uncertainty
Yeah.
will be a combination of the quality of the submission and the quality of the evidence.
Yeah, so it's indirect. I don't rate, because I don't have access to the submission itself, and the PSDs don't document whether the submission was of good quality or not. So it's hard to tell, but it does document the committee's view on the evidence before them. That's clearly documented, so that's what we try to extract. And that's obviously going to be a reflection of how good a submission it was and the various other factors around the evidence.
Yeah, thanks. The second question, sorry.
Somewhere there is a record of the committee's view on it because Medicines Australia asked us to provide advice, feedback to the companies about what we did, and there's a sort of informal vote taken at the end of the submission.
Of whether it was good submission or bad one.
What we sort of ranked it as
Wasn't that the
10.
hearings though?
But it's,
Oh, that's right, you're right.
Yeah,
That's
not
it.
the submission.
Sorry, it's not the submission.
but
Certainly I didn't submission.
Sorry, you're right.
just want to say to Stavros that the quality submission is always then moderated by the quality of the evaluation and the economic subcommittee's inputs, which often give alternative scenarios. So the sensory analysis that the ESC has done, the subcommittee has done, says this is a more reliable ISO than what the submission put in. That probably is going to be the basis upon which PBAC makes its decision. I'm pretty sure that's what this analysis was based on.
Okay.
So the Australian system is just a little different than NICE
Yeah.
because it allows for multiple inputs to the the decision.
The second question was about the cost effectiveness analyses, which are currently excluded. Could we do a separate analysis based on cost effectiveness analysis expressed in terms of incremental cost per life year gained? Or are there not many of those?
Let me go back to the numbers in a sec. I think it will depend on the numbers. I don't think we'll have the numbers to do that, I think.
I also think that a lot of those cost effectiveness ones are not going to be a cost per life year saved, because most of the cost per QALY ones will also have a cost per life year saved in them. So those ones there will be cost per additional responder, cost per exacerbation.
They just tend to be older as well, because though I haven't gone counted when they were, but my own personal reflection is in more recent years we get cost per QALY almost all the time. Yeah.